Well, hello, everybody, and thanks for joining us on RxSite Ed, an educational series brought to us by RxSite, where we can talk about light adjustable learnings using the light adjustable lens technology. Now, I'm Matt Jensen, your host, former administrator, CEO of Vance Thompson Vision for 20 plus years, now a consultant, and I'm joined here with my friend, Dr. Paul Karpecki from Kentucky. Hi, Paul.
How are you doing, Matt? Nice to see you again.
Good to see you again as well. I'm excited to talk to you about this technology because it seems like whenever there's some kind of new technology and especially with how to implement it, your name comes up somewhere in the process. We've known each other a long time. Maybe tell everybody a little bit about yourself and where you're practicing now, and then we'll get into some of our conversation about the light adjustable lens.
Sounds great. Thank you. I appreciate that intro, and I appreciate the opportunity to get to join you. So I do practice in Kentucky, in Lexington, Kentucky, which is central. I'm the director of cornea and external disease at Kentucky Eye Institute. And of course, external disease is a lot of dry eye. I think my clinic is probably one of, if not the largest, advanced dry eye clinics in the country.
You have a front row seat into the importance of a pristine tear film with any refractive procedure. And as we know, cataract surgery is the most commonly performed refractive procedure on planet Earth. Talk to us about the importance of corneal health, that tear film chemistry.
Yeah, that was really well stated and a great question, Matt. We can't overstate how important it is to have a pristine ocular surface when it comes to anything involving refractive error. I think we used to think of dry eye as this nuisance condition where people had burning and dryness and irritation. I think it's evolved over decades to us understanding this is a vision condition. I mean, you still can have symptoms, but the biggest thing it impacts is vision. And that ranges from something in primary care like spectacle remakes or contact lens dropouts, but especially in cataract surgery, missed outcomes and unhappy patients. And light adjustable lens is another good example. Yes, you have this wonderful flexibility of options you can do after. But if the patient's vision's fluctuating, you can't hit the target. It's caused by something else outside of the refractive error alone. And it's extremely common. So not only is a pristine ocular surface important in preoperative care, so you can kind of maximize your starting point and knowing what the biometry should be and getting close at least to the target. It's also real critical in the number of adjustments of an LAL you might have to do, which is it's difficult when you're shooting for a moving target. It might also be the outcomes afterwards of an unhappy patient who may have a very good refractive error after cataract surgery. It could be just the unpleasant experience of a person not getting the maximum effect of a premium IOL. So, and of course, it could even be a missed calculation where a patient is wanting the lens extracted if they shouldn't have flexibility like a light adjustable lens. So it imparts every aspect of eye care, even beyond cataract surgery.
You do a typical refractive cataract surgery patient candidate workup, really just be a cataract consult. And you're counting on so much of that to inform now your surgical plan, right? And, you want to make sure everything is just pristine when you get to that point. Not the least of which is that ocular surface. That's the window that we're looking through for all of the outcome. And then with some lenses, there's the one shot to have that nailed on the back end. And then there's this technology, the light adjustable lens, where, hopefully like in golf, we're just trying to get it, like a good putt, just try to get it 2 feet from the hole. And then we can, keep getting it closer. And those are other opportunities to also measure that ocular surface to see what kind of other noise there might be in there. Hopefully by then they will have had that rehabilitated or at least addressed. Talk to me about the difference between those two opportunities for deciding on what surgery, either preoperatively or being able to walk it in postoperatively.
Yeah, so obviously, ocular surface disease assessment is important in both. There are a lot of risk factors to dry eye disease that I think most doctors already know, to as far as what can be affecting the outcomes ahead of time and then later. And I mean, we think of obviously age, which is already there in cataract surgery. Gender, plays a role, but it's going to be half or more of your patients for cataract surgery. Digital device use is something we never had to think about 2 decades ago. They're a huge factor today. And then the usual things, the environment and smoking and certain ocular surface diseases, systemic medications, systemic diseases that can contribute to dry eye, contact lens wearer in the past. But one is, of course, ocular surgery. So you could actually get a patient who has maybe a few predisposing factors, an early ocular surface or dry eye disease, and then that might be the thing that may tip them over. Or they may have had ocular surface disease and it just wasn't addressed. So the point is, but whether it's the first treatment, the first surgery itself, the cataract surgery, or whether it's the light adjustable treatments, the light delivery device delivery to adjust and then lock in the refractive error, you still have to be assessing that ocular surface for both times. It's not a case of saying, well, I have adjustability, so they got a little dry eye, I'm not going to be too concerned, I can adjust it. Well, most patients with dry eye have fluctuating vision, and so you may have hit the perfect target. The patient just has blurred vision because of the dry eye, and then you try to move it, and now you're not on the target with an adjustment.
I'm just interested in knowing from a choreography standpoint. Imagine I'm a patient. I'm coming in for cataract consult. I have surgery. I have the light adjustable lens, and I'm excited to get my treatments done. Right.
Mm-hmm.
And I come in, and yet I'm not super confident. Let's say it's my second adjustment or something. And maybe you sense that lack of confidence. And there may or may not be something to do with some dry eye associated with that or not. Do you ever get to a situation where you say to somebody like me, I tell you what, why don't we can always delay this next treatment. Why don't we just put this off a little bit, go enjoy your vision a little bit more for a while, and then come back once maybe your ocular surface settles down a little bit. Maybe you're going to, prescribe them something else to do just on the surface of the eye. Do you ever run into that scenario where you're actually putting off an adjustment just to let their confidence grow and let their eye quiet down?
I think it's a terrific suggestion. I think sometimes we get pushed by patients, who this instant gratification, and I paid for this premium lens, I paid more, I want the vision as soon as I can. And sometimes not even the patient's fault. That's just our society. Or they had a spouse or a family member who had it done and they had vision recovery right away, and they're talking about how well they're seeing, and they think, oh, there must be something off with me. And many times when you have that hunch, you have to really go with it, go with the instinct of saying, you know what, there's no issue here with delaying things a little bit. We still have room to do adjustments that we wouldn't have had you not chosen this IOL, the light adjustable lens. So we can take our time. We can make sure that we get the ocular surface to a good level. We can look at some of the things that are there. And I'm usually doing that when patients are kind of iffy on their vision. They're like, yeah, it's good at certain times, and then it's not. You get little hints from patients like that, or your refractive error is particularly good and close to where it is, and the patient's still not stating the visions as what it should be. And so there's never a time where it wouldn't hurt to say, hey, let's build some confidence. Let's give some time for the ocular surface to recover. That's not an uncommon thing to say after a surgery. Patients are used to recovering after any surgery. It could be knee surgery, whatever. There's a recovery time. So it's not like the patient senses you're coming up with some idea that doesn't make sense. They're used to any surgery having a recovery, and the ocular surface sometimes has to recover. If you think about it, that front tear film is responsible for almost half the refractive error. So if we can get that in place, that tear to error or tear to cornea interface, it's going to have a big impact on your vision. And there's no patient who really wants to go and have an enhancement and turn out worse because they really did have the right refractive error. We just needed to improve the ocular surface. So I think they get it. I think that's not uncommon, actually, Matt, if we're looking for things like dry eye disease. And many times you do solve it by giving a little time. And then the next time they come back, they're saying, okay, I guess I didn't need that enhancement. Let's lock it in. So it is worth that pause.
I want to just ask about a little bit of the day-to-day flow and efficiency. You know the folks, and I know them too, who walk up to me at the meeting and they say, boy, I would do that, but it just takes way too long. What do you tell those folks?
It really doesn't with the right expectation. Now, I tell them both, I tell you the truth, Matt, I do tell them that is a potential that it can, but there are ways to streamline, and that's why I like the way you asked that question, the flow so that it really doesn't. And I think that becomes very important. And that also helps, surgeons decide if this is for them. While I love the technology in the sense that we have the adjustability, you don't have to do as much of the preoperative measurements. You need to be, like you said, within a couple feet of the hole with the golf analogy, and because you have other shots of tapping it in, which you wouldn't have with other IOLs very easily. It makes it seem, well, that means there's less time involved. And while there is, I think we have to ramp up our game in cataract surgery across the board, where we are looking for blepharitis more carefully, which can affect the tear film because of the MGD it causes. We are, expressing the oil glands. We're putting fluorescein stain in and looking at the cornea and the conjunctiva. You don't have to buy another lissamine green. If you just get like a number 15 yellow Ratten filter and use fluorescein stain and put it between the patient and the slit lamp, you can light up the conjunctiva staining just as well, if not better, than lissamine, for example. So you can find ways to streamline things. Osmolarity can give you an idea of what's going on. But I don't think that necessarily is just light adjustable lens. I think you should be doing that on every IOL that comes in, because that's probably one of the number one reasons for missed IOL calculations and for unhappy patients. So you're not adjusting anything there. But the reason I say that's so important for light adjustable lens is patients know that's the only one they can adjust. And they don't know if the reason their vision isn't fantastic or where they need it to be is because the calculation was off on the refractive error or because of dry eye. They really don't. I mean, those who have a lot of symptoms knew it ahead of time. Most of the patients don't realize it until afterwards. So that tells you that you will save a lot of time post-operatively. And that's where I think doctors get worried. You'll save a lot of time post-operatively if you look for these things in the ocular surface ahead of time. And that exam that I just described, osmolarity is 1 minute. Looking at the eyelids and expressing the oil glands is 45 seconds. Putting the dye in, now that takes an extra minute for it to equilibrate before you can look at the eye. But just that fluorescein dye, you can look at tear breakup time. Just glance at it. You don't sit there and measure it. More importantly, you can look at corneal staining, especially if it's central. You can look at conjunctival staining with the number 15 yellow Ratten filter. And you can look at the little tear meniscus height. And again, you don't need to measure these things. You get good at knowing what normal tear height is. With just that, you pretty much have your entire assessment. I mean, honestly, I hate to say it, because I built my career on this area of dry eye, but it's a 3-minute exam, tops. And you've got all the information you need.
Well, listen, the last question I have for you, Dr. Karpecki, is just what advice you might have for practices who are considering implementing the light adjustable lens technology. Where would you have them start?
I would really start with kind of these triaging questions that I've been using for a long time, but they really address a lot of what's going on. And they're really just 5 simple questions that are common sense more than anything. As you hear them, you're all going to kind of know them, but they go after the ocular surface. And one is, do your eyes feel dry, gritty, irritated, burn, sting? Something that itch, that sort of thing, that just gets at how do they feel going before you do your assessment. Number 2, how do they look? Are they red? Do they look irritated? 3, do you experience fluctuating vision? That's really an important one to differentiate dry eye disease, vision that changes with the time of the day or with the blink. Do you have the urge to use artificial tears, or are you using them? And I say urge because I had one patient who came in, I said, are you using artificial tears? And they put no. Come to find out, the answer was no, because they had tried every possible artificial tear under the sun and none of them worked. And so they haven't used any for like the last 6 months. So even the urge to, because your eyes don't feel good, becomes really important. And then the 5th one's a little rhetoric. How much time do you spend on digital devices? But it does help patients to understand that there's a connection between the amount of digital device time and dry eye, so that they can understand why they're developing and why it's happening. But the first 4 would help you identify it. And then you can say, okay, based on the fluctuating vision, we're going to pay attention to that ahead of time because we have to get that well controlled. Now, you should do this for any cataract surgery because you have to be able to get them to a level where your outcomes are optimal. So they do tell patients about how well they're doing and they get the best experience. But I think those 4 simple questions, then the last one, which addresses just digital devices, but those 4 first questions will help almost triage the patient that you need to do an assessment on. And then assessments are straightforward. I mean, if they have symptoms, like maybe just a speed questionnaire or a DEQ-5 or something that just tells you, somebody's just asking them on history, and they have some sort of sign like hyperosmolarity or ocular surface stain or rapid breakup time, especially non-invasive, and you know that it's an evaporative dry eye because the expression of the oil glands is bad, and you've looked for blepharitis like collarettes by having the patient look down, and you know it's an aqueous deficient dry eye, meaning not enough tears if the tear meniscus is really low. Your fluoresceine's already in the eye to identify that. You've got the full assessment, and so you now have figured it out ahead of time. And then, to be fair, it is best to treat that. And treatment is fairly straightforward. By the way, you are really looking at, I mean, nothing more than if the symptoms in the morning, there are little tests to check for how the eyes close. But let's take the evaporative dry eye. 86% of dry eye has some evaporative component, which means there's some meibomian gland dysfunction. You're going to have to get the oils a little better before surgery. That could be compresses. It could be an in-office procedure like an IPL or thermal pulsation. It could be, even just omegas or something to get that going. Number two, you have to clean up the eyelids, whether it's one of the new therapeutics or whether it's an in-office cleaning. Three, you'll have to treat inflammation. It's almost always there. And that could be a short course of corticosteroids. It could be immunomodulators. And then, you've got to start by treating the tear film. Hopefully it gets better. And that could be new perfluorohexyloctane, any of these other things that have come out. So the point being, just something as simple as a hot compress, lid scrubs, an omega, and a tear might get the patient where you need them to be. You got to be more aggressive if there's more disease. But I would look at those things. I'd get them to a good level, and you're going to be amazed at how well patients do with the outcomes and with the number of required enhancements that are present. So I would, one, look for it, and that's those 4 triaging questions especially. I would do an assessment like we described, and then I would take on a basic treatment like we just went through. Obviously, a Sjogren's or a aqueous deficient dry eye, you're just dealing mainly with inflammation and getting the tear volume up. That's one where plugs are valuable and inflammation control. But don't make it complex. Just there's only really mainly 2 main categories of dry eye, even though there probably are 4, including exposure. Those main 2 in the majority of patients, and as you address them, you're going to find it is worth the investment for your patients and for your outcomes and for the thing we talked a lot about today, which is the amount of time involved. You minimize the time involved and you enhance the outcomes when you take these extra steps ahead of time. So that would be my only advice. And that, recommendation, that goes along with setting the proper expectations. If those are in place, it's easy to have great success with a technology as good as this one.
Well, Dr. Karpecki, great comments there. Now, one question that I have as we're talking about ocular surface issues is how might providers see that in ways that aren't typical? If they haven't done all the testing, I mean, can they observe some noise in the refraction? How might they stumble upon it?
I really like this question because we talked to, we kind of, real important to ask patients about fluctuating vision, to ask patients about eyes that are gritty, red, using artificial tears. That's all important. But the point is that many times patients don't put any sort of blurred vision together with the potential for dry eye or ocular surfaces. Yeah, there's a lot of information you get out of the phoropter. If you have fluctuating vision, you have to repeat it. If the patient can't really differentiate amongst a number of times, if it looks like they had the right final refraction and then it changed, if they have to blink or stop, if they say one moment, and you notice behind there, they're blinking to clear it up. I mean, of course, if a technician had to put an artificial tear in, that should have given you the idea of what's going on. But I think you're going to get all of those as wonderful cues to the fact that this patient has some sort of an ocular surface or dry eye disease. And, you don't think of the phoropter and keratometer and other things as dry eye tools, but because dry eye is such a vision condition, they become wonderful tools for assessing and maybe determining if someone has dry eye disease, even if they're not mentioning it in their symptoms. And you wonder, well, why wouldn't they mention it in their symptoms? Well, we keep moving up our level of norm. It becomes common with a slow-moving chronic condition that you adjust to where you're at. And then while you might have had symptoms early on, you kind of don't think about them. And unfortunately, with dry eye, you do get a nerve downregulation with time where you get less symptoms as the disease progresses. So using other instruments to determine changes in stability, such as a phoropter, become really valuable tools for determining if there's dry eye disease.
Well, and the phoropter really is the lowest common denominator, right? If we listen to that first before we go on to any other therapeutic, diagnostic device that's looking for pathology or whatever, I think that's a really astute way. Have your technicians or your optometrists or your providers listen to that phoropter and how they're talking about doing that exam. A great first step in diagnosing anything going on with the ocular surface. Well, I think that that's a perfect answer on how to really consider implementing the light adjustable lens is to do it in conjunction with paying attention to the good ocular surface for the best refractive outcomes. And I think that, like you mentioned throughout our talk today, Dr. Karpecki, to be able to do that preoperatively and assess, many providers want to have that all done so they can move on with surgery. But as we know, sometimes surgeons want to move ahead and then do the rehabilitation afterwards. That's the present reality we have. And in either scenario, the light adjustable lens is serviceable with both, right?
That's
because
true.
we're still zeroing in on their best visual outcome post-operatively. So it's set up for that kind of conversation. You are a true specialist in all things anterior segment and especially the tear film, Dr. Karpecki. I really appreciate you joining
Thank
us
you.
to talk about the light adjustable lens. And everybody, I want to thank you for joining us for this session of RxSight Ed, an educational program that we have for light adjustable learnings with the light adjustable lens and the LAL Plus, brought to you by RxSight. Thanks, Dr. Karpecki, for being such a great panelist, and I look forward to talking to you again, my friend.
Thank you, buddy. It was a real honor. Appreciate the invitation.
Yeah, thanks everybody for listening.
Well, hello everyone, and welcome back to another session of RxSight Ed, an educational forum where we're talking about the light adjustable lens and its usage in the practice. Now, again, I'm joined here by my friend and colleague, Dr. Paul Karpecki, who is really world-renowned when it comes to the ocular surface and the focusing ability of the eye. And we've been talking a lot in our past conversations, Dr. Karpecki, about how the light delivery device and the light adjustable lens really serves the patient well, and them being able to assist in dialing in the vision that they want. But as you know well, and I'd like you to talk about a little bit, how does the ocular surface, especially post-operatively, affect when and how you do that light treatment?
Yeah, that's a great question. Great way to start this. I think most people know the importance of the ocular surface, but that I think just to emphasize that tear film to air interface is responsible for up to 45% of the refractive error. So you got to think, well, the lens plays a role, but not as much as that interface to the tear film. So if it's not optimal, if it's not really where it should be, the other really important aspect is that dry eye disease or ocular surface disease is truly a vision affecting condition. We always think of the eyes being irritated and dry and gritty and burning and maybe some itching. But we have to also realize that blurred vision, especially fluctuating vision, is a hallmark sign of dry eye, and it's going to affect the refractive system as a whole and even offset any accuracy or inaccuracy within the lens.
Well, and so what are some of the things that people should be looking for post-operatively when they're seeing these patients a few weeks after their procedure, but as they're looking at doing their light adjustment or even their lock-in?
Yeah, I think, I would even, believe it or not, start with symptoms just as a whole. Maybe, are you experiencing any fluctuating vision? Just to get an idea. If that's present, then it's obviously not related to the lens or to the IOL. That would be more of a very consistent blur. Now, you can have dry eye, especially if there's punctate keratitis, where the blur is consistent, but more often it's fluctuating. I would ask if the eyes, how do they feel? Do you have any dryness, any irritation, any itching? Are your eyes red? Have you had the urge to use or using artificial tears? Even how much time on a digital device? All of those are good, more or less triaging questions to help you determine if someone may have some ocular surface disease issues. And I always like to ask, can you clear your vision with the blink? If you're able to do that, then it's clearly from the ocular surface, from the dry eye, from something that's playing a role. not related to the refractive system of the lens or even the cornea itself. So it is definitely that blinking to clearness, or putting an artificial tear in that clears it up, that tells you, okay, we don't want to, if it's an LDD procedure, we don't want to touch this or change anything until we absolutely know that's stable. And if it's a pre-cataract patient, as you asked about, we have to address that. Alice Epitropoulos did a study many years ago that found that something like 17% of patients who had hyperosmolarity missed their IOL calculation by more than a diopter. That's a significant
Wow.
impact in patients who have dry eye, and it becomes a moving target.
Well, and I know that you do this, but oftentimes you're not waiting until post-operatively to start discussing these things. You're addressing these things, in the weeks leading up to their consultation and surgery as well. What are some of the ways that you treat ocular surface issues prior to surgery?
Yeah, well, it depends a little bit, Matt, on the type of dry eye as a whole. So I'll start a little bit with that. There's some good preoperative testing that are quick and easy to do, like osmolarity. You just have to have a well-trained staff. That'll give you an idea if there is dry eye. Tear breakup time is another indicator of dry eye. It doesn't tell you the type. A person with evaporative dry eye, where their meibomian glands aren't functioning well, might have a rapid breakup time. But a KCS patient with Sjogren's syndrome will have an even more rapid breakup time. So it doesn't tell you the types, but it does tell you it's present. So any of those type of tests are very helpful. But you got to really start, pay a lot of attention to the eyelid. You got to look for indicators of meibomian gland dysfunction, like froth in the tear film, which is saponification, where the oils are mixing with dysfunctional oils are mixing with enzymes from bacteria or Demodex, and causing that. You have to express the oil glands. It's a simple technique where you just push on the eyelid, see if you can get olive oil to come out. It comes out like toothpaste or turbid, or it can't express. That's a big indicator. Look for telangiectatic vessels on the eyelids, which indicate rosacea. You pretty much have a lot of inflammation, or an ocular rosacea case, the meibomian glands are going to be affected. Sometimes there's capped glands, collarettes at the base of the lashes, debris in the tear film, thickened eyelids. There's all these little hints that are there. As the patient looks down, you can see sometimes blepharitis a little more readily at the slit lamp. But ultimately, you do have
And
to
I've heard you and your colleagues talk about this post-operatively too, how when a patient's in front of you for maybe a second light adjustment, how you might have some evidence of ocular surface issues, but the presentation will actually be more in lack of confidence, right? Like, I'm not sure if I like this or this better. And in cases like that, it's a kind of a layup question, but do you charge ahead with the treatment, or do you try to take a little time to rehabilitate that tear film and bring it back around?
And those are great indicators, especially at the exam level related to the cataract surgery or to the LDD procedure. Yeah, anytime you see, best corrected vision that doesn't match up, that'd be a big indicator that something more is going on. I mean, especially the LDD, because they've already had surgery. So they should have really good correctable vision. If it's not there, let's start looking at the ocular surface by looking at the eyelid. Putting some fluorescein in the eye is very helpful too. Second is, cylinder. If all of a sudden you're seeing a refractive error that has changed, where now there's a diopter, a cyl that you didn't have early on, that's dry eye, that's ocular surface issues. That's not going to be something in a lens or suddenly changing. And as you said, the patient who really has difficulty on the refraction of differentiating 1 from 2, and they sit there for a moment, they're probably blinking behind the phoropter. That obviously is telling you there's ocular surface issues there. And then I'd keep it simple. Ask a few questions. I said press on the eyelids and just put a little fluorescein in the eye. Look for staining of the cornea or the conjure, or even the tear height. And that's all you need to do. And you'll be amazed at how often you pick up ocular surface disease.
Well, this is a topic I think that's appropriate for really any part of refractive surgery, and you're well known for it. But also, since cataract surgery is the most commonly performed refractive surgery, right? Because we're totally redoing the optical system. I think it's something we always have to keep in mind, is to pay attention to that tear film. I want to thank you for your time and your commentary there, Dr. Karpecki, and it's good to chat with you about these things as usual. And I want to thank RxSight for putting together this program, RxSight Ed. the educational series about how to use the light adjustable lens within your clinic and practice. Thanks, Paul, for joining us today.
Glad to, Matt. Thanks for the opportunity.